So thank you for the introduction. So just a little bit more about me, just so you know. I'm actually from here, grew up in Palo Alto, graduate of Gun High School, went away a couple times. Now I've been back here almost 10 years, and grateful for the opportunity to give back to the community, both as a physician and then also to provide lectures like the one I'm going to provide tonight. So it's sort of an interesting topic. I kind of chuckle because this is like a Palo Alto topic. Everywhere else I go, people want to know about the surgical treatments for vascular disease. But I was asked to speak on whether or not there's a holistic approach to treatment. And actually, when we talk about actual interventions, it really is part of a holistic treatment, which is why I think it's actually a good way to frame the disease. Holistic, if you look it up in a dictionary, and I put this in because my mother was an English teacher at MA, so I have to always make sure that I'm proper in my use of words. Characterized by the treatment of the whole person, taking into account mental and social factors rather than just the physical symptoms of a disease. And I think that's important because as we go through this, what I hope to convey to you is that peripheral vascular disease is just part of a constellation of cardiovascular disease, and a lot of times it's sort of the first diagnosis that allows people to realize that there may be other things going on, and it actually provides an opportunity for all of the risk reduction that we now know is so successful to be begun. So I'm going to take hopefully about 30 to 45 minutes. I'll try and keep it in that time frame. So if you do have questions, either about the talk or about vascular surgery, about our clinic in general, and I'll give you another little tidbit at the end, which I sometimes are reluctant to give, but I will give it to you so we can have a conversation afterwards. Vascular disease is very common. It's a leading killer in the United States, cardiovascular disease. Since 1990, more people have died from cardiovascular diseases than any other causes. These include heart attack, stroke, sudden death. Almost 1 million American lives are claimed by atherosclerotic disease yearly, and it's actually responsible for more deaths than cancer, accident, HIV combined. So it's very common cardiovascular disease. We're going to focus today on peripheral arterial disease, or PAD. You'll sometimes hear me using that abbreviation, and I apologize. Sometimes we start talking in our vernacular, so I'll do my best to stay out of that. And peripheral arterial disease is a small segment of vascular disease, which is a small segment of cardiovascular disease. But as I said, you'll see how these are all related. So we'll talk a little bit about what peripheral arterial disease is, who tends to get it, what happens, what the natural history is, what happens when someone has a diagnosis, and what some of the things that can be done for it. What I've found talking to communities is to sometimes start way at the beginning. This may be very basic for some of you, but it just sort of helps us get on the same page to begin with. That's just a little basic primer on circulation. And basically, the circulation has 3 components. The first is the heart, which is the pump that pumps the blood. The second component is the arteries. The arteries are the pipes from which the blood travels from the heart to the tissues. And then the veins bring the blood back to the heart. So peripheral arterial disease is a disease of the arteries. And a lot of times you'll hear us talk about circulation problems, and this can sometimes be a little confusing because we see a lot of patients who come into our clinic with vein problems, which, are actually part of the circulation, but we, as vascular surgeons, look at vein problems separately than arterial problems. And when we talk about circulation, we're usually talking about the arterial side of the circulation. And for peripheral arterial disease, it's the arterial side. So this is a problem with blood getting to the tissues. So, and that's what causes the symptoms and the problems. Basically, what peripheral arterial disease, it's atherosclerosis, hardening of the arteries, blockages of the arteries. These are all different names for the same thing. Let's see, I don't have a pointer, do I? All right, well, I'll try and use the mouse if I can. I'll try and use it. All right. So this is a normal artery with an arterial wall, and the flow channel has blood cells in it, travels blood. Over time, you can get buildup of the muscle wall, which is smooth muscle, or buildup of debris, including lipids, which is a form of fat, calcium, dead cells, which causes these narrowings. And then over time, the narrowings can go from a small amount of narrowing to a great degree of narrowing. What we know is that if the narrowing is present but it's not severe, patients can actually not have any symptoms at all. And so they have early stages of the disease, but they don't have symptoms. And we'll talk a little bit about that in a few minutes. In fact, we'll start right now. So when people have blockages of the arteries, they can present with a continuum of symptoms. Sometimes patients come in, they have no symptoms at all, and a primary care physician happen to identify vascular disease from an abnormal physical exam. Typical symptoms, what we call mild to moderate symptoms, are the medical term is claudication, which is Latin for limping. And basically what happens is patients get cramping when they walk. And the reason for this is that the muscles in your legs require more blood when you walk than when you're resting. So when you're resting, either sitting or standing, you can get plenty of blood. You don't have any symptoms. But when you start to walk, after a while, the supply of blood can't keep up with the oxygen demand of the muscles, and so you start getting cramping. Generally, with this kinds of symptoms, when you stop walking after 2 or 3 minutes, the pain goes away. We're going to focus most of the talk on the asymptomatic group and these, what we call claudicants, the mild to moderate symptoms. And not because it's necessarily the most important, but I think this is the group of patients where this holistic treatment becomes really important. It's only a portion of what I do as a vascular surgeon, but that's what we're going to focus on tonight. At the other end of the spectrum, though, there are patients who can have severe symptoms, and these severe symptoms put them at immediate or very short-term threat for amputation. And this would be pain in the feet at night, where you have to, when you're lying down, you get cramping in the midfoot over the arch, and you have to dangle your feet to have the symptoms go away. Or we can have patients who have wounds that don't heal, or they can present actually with gangrene of the toes. I will say that this disease is most common in the legs. It's very unusual for us to see this in the arms. We do occasionally see it, but for the most part, we're going to be talking about circulation to the legs, because that's really how peripheral arterial disease tends to present. So if you Google claudication or vascular disease, you'll typically see these kinds of pictures where you have someone grabbing their calf to sort of visually signify that they get cramping when walking. And the reason why this picture, I think, is appropriate is that when cramping occurs, this is usually where it occurs. It's in the large muscle areas, so it can be in the calf. That's the most common place. It could be the front of the thigh, which is less common, or it can be in the buttock, which is even less common. But it's usually in the large muscle groups of the legs. So it doesn't occur generally in the front of the calf or the back of the thigh. If patients are coming in with pain in the back of the thigh, it's generally actually something else. We'll talk about that also in a minute. Now, when we as physicians evaluate patients for peripheral arterial disease, there's a lot of other things that can cause very similar symptoms. And part of what we do is to really sort of separate if the symptoms in the legs are caused by a vascular problem or if they're caused by some other problem. We see a lot of patients, for example, who get night cramps, where they get cramps in their calves at night. That's almost never a vascular problem. And fortunately for us, when we see those patients and we examine them and we study them, their vascular system is normal. We can reassure them that they don't have any significant vascular disease. Doesn't help with their symptoms, which is a little more challenging, but at least in terms of eliminating the possibility of severe problems we can do that. Sciatica, spinal stenosis, these are other causes which cause nerve compression, and the symptoms for these conditions can be very similar to what we call vascular claudication or peripheral arterial disease. Also heart conditions where the heart isn't pumping well, so the legs aren't getting good blood flow because of the heart, that can also mimic the problem. So these are some of the things that we may look for. Now, the reason why I put these two pictures up is, given what I just described, here's a picture of a woman grabbing her knee, and then here's another picture below that of a man grabbing the back of his thigh. These are not the typical symptoms that we see with peripheral arterial disease. But the reason why I put them on the talk is that these pictures also showed up when I Googled claudication. So it's just a reminder that be careful with what you read. Come to our website, you get really good information. Because generally when we see patients with these types of complaints, it turns out their vascular status is normal. Who gets peripheral arterial disease? So this is a disease generally of older people, as well as smokers, diabetics, and those with hypertension or coronary heart disease, angina and so forth. These are all related. They're not necessarily caused by the same, for the same reason. There's actually some very interesting genetic studies which have shown that some of the genetic abnormalities which can be attributed to heart disease are in the same gene as some of the genes for vascular disease, and that's why we think that why some of these diseases tend to track together. I'm going to show you a number of studies that were done between 10 and 15 years ago. These are very large studies looking at the prevalence of peripheral arterial disease, and the reason why I put this up is that the prevalence, meaning how common is it in the population, depends on what population you study. So NHANES, which is a national survey study, looked at everyone over 40 years old, and they found less than 5% of people. The same group looking at patients aged 70 years and older was about almost 15%. So it's about 1 in 6 patients. And at the bottom, the partner studies, and what this is these are patients who are either 70 or older, or patients 50 to 70 with a history of diabetes or smoking, almost a third. And so these are the types of patients who are at risk. Doesn't mean that everyone in these risk groups actually have the disease, but these are the conditions that tend to be associated with peripheral arterial disease. This is just an example of a couple studies. One was a study from the Netherlands in red, and the other was a study from San Diego. And basically what this shows is that the prevalence of peripheral arterial disease increases with age. This is a study looking at gender differences. The disease tends to be slightly more common in men than women until you get above 85, and then it's much more common in women than men. And actually the reason why we think that is that coronary disease in women tends to lag about 10 years behind coronary disease in men. So there's a little bit of selection here where some of the men who may have had it may not live past 85. There's also some differences based on ethnicity. It tends to be more common in African Americans, and this is especially true even after adjusting for differences in smoking history. This may be thought to differences in hypertension and high blood pressure. The hypertension in African Americans seems to be a different type of hypertension than hypertension with folks of other ethnicities. And then, at least in this particular study, NHWs, non-Hispanic whites, was sort of a moderate risk, about 5%, and then Hispanic lower, and then Asian lower than that. And then this is a slide showing the risks between diabetes and peripheral arterial disease. These are patients, age 70 or older, and the yellow shows patients who are not diabetic, who have normal glucose studies. The red are the so-called pre-diabetics, so impaired glucose tolerance, but not actually diabetic, and then the green is diabetic. So you can see it goes from 12.5% up to 22.4%. And so, and the reason why these are important for us is when we identify someone with vascular disease, if they have these other conditions, it becomes very important to make sure that these are maintained. I'm going to show you why in a minute. So, when a patient has a diagnosis with peripheral arterial disease, especially, if they have it in the presence of all these other things, what does that mean? So, these were some studies that looked at that to see what the natural history of the condition was. I'm going to spend a few minutes with this, and I'm sorry I don't have a pointer, but if I touch this thing, it's going to go to the next slide. So you can see in this study, anywhere from 20 to 50%, most people say about a quarter of patients are asymptomatic. So these might be patients who come to their primary care doctor for diabetes care or coronary disease, angina and so forth, and someone does a pulse exam and finds some abnormality, but when they question them about whether or not they have the claudication or trouble walking, they don't have any trouble. Now, it may be that they have shortness of breath from their heart disease or shortness of breath from lung disease if they're smokers, and so they can't walk far enough for disease. Sometimes the disease can just be very mild at the time that it's diagnosed, and they don't have symptoms based on that. About a half to 3/4 of patients have some kind of leg pain. Some are atypical, and some have the typical claudication, which I described. With the patients who have atypical leg pain, that can be very challenging because a lot of times the cause for their symptoms may actually be one of those other conditions. And so really the peripheral arterial disease is asymptomatic, and we happen to find, for example, a nerve root compression because their pain was atypical. We identified vascular disease, but on further workup, it turned out that the nerve compression was actually causing the symptoms. So that's what that little group is. And then these critical limb ischemias, these patients who I told you about who have rest pain or non-healing wounds or gangrene, that's only a very, very small portion of patients with vascular disease, only about one or two out of 100. And those patients, when they have a lot of disease burden in the legs, not surprisingly, they have a lot of disease burden in the heart and in their brains. And so a lot of these patients end up with either an amputation or they die either from a heart attack or stroke in just 1 year. So these are the patients where the interventions are really important. And that's why for today, we're not going to talk about them. So that's really the majority of what we do in our practice. We see those patients with the critical limb ischemia, but I wanted to focus today on some of the holistic approaches to this, which is really 98% of the patients who have vascular disease. Now, when we see someone who's asymptomatic or has claudication, this is if you have those symptoms and you're going in to evaluate treatment, this is probably the most important slide. And the reason for that is if you're going to decide on a treatment, you need to know not only the benefit of the treatment and the risk of the treatment, but what's the risk of just leaving it alone? Because a lot of patients will come in and, for example, they say, I get cramping in my leg at 3 blocks. And I'll say, well, does that interfere with the things that you want to do? And sometimes patients will say, well, yeah, I want to go hiking, I want to do a lot of things. But sometimes patients say, honestly, mostly I can do 99% of what I want to do. You can imagine that each of those different patients might have a very different attitude in terms of what treatment they may want to lean towards. So if you look at a patient with mild to moderate disease, 80% of those patients 5 years from now will have exactly the same disease. They won't have progression, they won't have improvement, but it'll just be the same. And this is why it's important when we see patients with moderate disease to get a sense of how much it's really interfering with their lifestyle, because the natural history of this is actually fairly benign. About 10 or 20%, the symptoms will get worse over time, and those patients may be interested in an intervention at that time if they hadn't chosen an intervention at the time that I would originally have seen them. And then again, only about 1 or 2% move on to this critical limb ischemia. And so this becomes very important because if the risk of the treatment is higher than the risk of the natural history, we tend not to be too aggressive in what we recommend, especially if it's not interfering with lifestyle. Sometimes we have patients where it really does interfere with their lifestyle. They may be working, for example, and they just can't do their job because they have too much pain. And we might take a more aggressive approach for somebody like that, and the patient may really request a more aggressive approach. So that's sort of when we talk about treating for either angioplasty, stent, surgery, that's what we're up against. And now for the critical limb ischemia, it's very different because we can do much better than the natural history if they present in that way. But for the patients with just moderate symptoms, that's an important conversation to have. That's half of it. That's the one half. The other half is what it means to your body if you have peripheral arterial disease. And this is the important part because a lot of these patients, atherosclerosis, it occurs throughout the body in all the arteries. And if it's occurring in the heart or the brain, then that puts a patient at risk for stroke or death or a heart attack. And it turns out that about 1 out of 5 patients with claudication will have either a non-fatal stroke or a non-fatal heart attack, and another 25%, so another 1 out of 4, will die within 5 years, and 3/4 of them will die from either a stroke or heart attack. Some, of course, will die from other things. And so the important take-home message from this, if you have PAD or if someone has PAD, is that it's a marker for increased risk for heart attack, stroke, and death. And so when we talk about treatment, we're talking about not only treating the peripheral arterial disease and the symptoms of the claudication, the cramping, but also the underlying risk that it carries with it. About 40% of patients with peripheral arterial disease will have a heart attack, a stroke, or a cardiovascular death within 5 years. And in fact, these cardiovascular events are more common than the complications of the circulation in the leg for these patients with moderate disease. So that's like super important take-home message. So you may wonder how we diagnose this or how your primary care physician diagnoses this. It starts, of course, with a history. And what I have here on a slide, it's a little busy and we don't really have to go through the whole thing, but basically this is how we teach our house staff, our residents, how to differentiate between claudication from circulation versus claudication from vein problems, which can happen, or claudication from nerve compression, which is actually the most common cause for claudication when it's not a circulation problem. And so we ask questions about the quality of pain, how it starts, how it's relieved, what muscles are involved, if one or both legs are involved. And very frequently, from just getting a really good history, we can tell if, in what direction we're going. Sometimes you can't. And to confirm, do a physical exam and some testing. Physical exam is basically just checking the pulses, much like when the doctor or nurse checks your radial pulse in your wrist. We can check pulses all up and down the arm, all up and down the leg, and see if they're present, if they're absent, if they're diminished, which can sometimes give us a clue. If the pulses are present and they're normal, that essentially 99% of patients eliminates the diagnosis of peripheral arterial disease. Sometimes we can find patients with very mild disease in that situation, and so the other thing that we will do is an ultrasound test. We call it an ankle brachial index. There's 2 ways it can be done. It can be done with a handheld device, which is this picture up here, or it can be done with in our lab. We have the big equipment because we use ultrasound as well as as well as pulse volume recordings, and we'll get a map out of that looks something like this. And basically what we're doing is we're comparing the circulation in the arm, which, as I said, tends to be normal, even with patients with peripheral arterial disease, with the circulation in the leg. And so we can make a diagnosis based on those things. Once someone has the diagnosis, and we start talking about treatments, because there's these two arms of the disease, the local symptoms and the cardiovascular risk, we really talk about treatment in terms of both symptoms and the cardiovascular risk reduction. And basically, sort of the 30,000-foot view, it basically involves lifestyle modification as well as medications. Lifestyle modification, smoking cessation, if a patient is a smoker, by far the most important thing. And I would say that would be our number one holistic treatment. Not the easiest thing for people to do, because if quitting smoking were easy, nobody would smoke, because we all know it's bad. But a lot of the other treatments that we can offer, including medications and interventions, are really their effectiveness is truly blunted by ongoing smoking. So it's something that I really encourage is smoking cessation. For someone who's diabetic, we really want them to be under good diabetic control, especially if they have wounds, because wound healing tends to be impaired if their sugars are out of control. Regular exercise training, which I'm going to talk about a little more, and then there's a variety of medications. Some of these, and we'll talk about these some more as well, some of these are for symptoms, some of these are for cardiovascular risk reduction. So I'll talk first about improving symptoms. And there's a process that's sort of crept into the medical literature over the last 5 to 10 years called shared decision making. I think that this is a situation where shared decision making is really important. Basically, what this is a sort of a diagram of different types of decision making, sort of the old Marcus Welby traditional, what we call paternalistic decision makings, where the doctor tells you this is what we're going to do, and the patient says, yeah, sure, okay, whatever you say. That's sometimes patients, want the physician to tell them what to do. For mild to moderate claudication and peripheral arterial disease, it's not the best way to go about it. There's also what we call informative, which is where the physician gives the patient information and then the physician makes the decision. And then the third, and I think probably the best decision making for this particular condition, is shared decision making, where there's a conversation between the physician and the patient about the benefits and the risks of the various treatments, and then a sort of a shared decision as to what makes sense for each individual person. This is especially true when we're talking about interventions, because the interventions carry risk along with the benefit. So the non-interventional therapeutic options, there's really two. One is an exercise program. The other is a medication called Cilostazol. The trade name is called Platol. There's both what we call level 1, meaning really good evidence that show that these are really beneficial for the treatment of mild to moderate peripheral arterial disease for improving symptoms. Exercise has been shown to increase someone's walking capacity for anywhere from 100% to 200%. So if a patient comes in with symptoms at 1 block, they may be able to walk 2 to 3 blocks at the end. Likewise, if they come in with 2 blocks, which is a typical length for an untreated patient, they may be able to walk 4 or 6 blocks, which is basically a quarter to a half a mile. And you can imagine for many patients that may be adequate. Cilostazol is a medication, and so the limitations of the exercise program is that it's an exercise program, so it takes a lot of motivation. It up until very recently was not a covered benefit. So unlike supervised exercise programs for cardiac rehab, which have been covered for a long time, vascular rehab has never been a covered benefit. Although just 3 months ago, Medicare has agreed to make it a covered benefit. We don't have details yet, so we can't actually roll out the programs, but that will be forthcoming fairly shortly. Cilostazol or Platol is a medication which has been shown to increase somebody's ability to walk by about 50%. So if someone can walk 2 blocks before the treatment, they'll be able to walk 3 blocks after the treatment. And again, a lot of these decisions depends on how much benefit the patient, any individual patient, may be looking for. There are some side effects with the Cilostazol, and we'll talk about that in just 1 second. So a little bit about the exercise therapy. If you are interested in what's been shown to work, This is supervised exercise therapy, meaning that you have a trainer or somebody there to make sure that you follow the program. It's 3 to 5 sessions per week, 35 to 50 minutes per session. It's done on either a treadmill or a track, and it's done to what we call near maximal claudication pain. So sometimes patients will say they'll get symptoms at 2 blocks, and at 4 blocks they have to stop because they just can't take it. So we would start by having them walk a distance of perhaps 3 blocks. So further than it takes to start the pain, but not so far that they just absolutely have to stop. The programs are anywhere from 12 to 26 weeks, and again, the results are very good in terms of improving the walking distance. And the other benefit to this is that the improvement is obtained with a combination of muscle training, because it's no different than what athletes do for training, and development of collateral circulation. So the results tend to be permanent as long as the disease doesn't progress. And so the results tend to be long-term. This is a typical exercise pattern of how these programs work. There's warm-up, exercise, rest, exercise, and then cool down. And again, the warm-up is about 5 minutes. They do the exercise and you rest until the symptoms completely go away, which tends to be about 3 to 4 minutes. As I said, CMS just agreed to pay for 36 sessions during a 12-week period, so that does fit within this category. The decision just came out a couple months ago. We're still waiting for recommendations for the insurance providers for how to submit and how to process and what the reimbursement's going to actually be. So many places, including Stanford, is gearing up for this, but in terms of how we staff this will depend on how Medicare will able to reimburse us. Unsupervised exercise has not been shown to be beneficial. It's not that we don't recommend it, but we do tell patients that because it takes a lot of motivation, the unsupervised programs may not be as beneficial. And this may be because of inability for patients to comply with these minimum exercise level. They may not progress their exercise levels, their distances as their symptoms start to improve, or sometimes patients are just nervous about walking and pushing it when they don't have anybody with them. So the Cilostazol, as I mentioned, is the only medication that we recommend. There used to be another medication called pentoxifillin. It was called Trentol, and the evidence is really not very strong that it was very helpful. It took many weeks for patients to take it. There was a lot of issues with both nausea and diarrhea, and then since Cilostazol came out, it's just been a much better drug. The only major thing to mention is that if someone has heart failure, then the drug is contraindicated, meaning that it shouldn't be taken. This is really the landmark study that showed the differences. Basically, what this is showing is across the bottom is how many weeks of the patient was on medications, and the y-axis is the change from baseline in terms of walking distance, and so the higher the line, the better the drug. The the solid line and the dotted line at the bottom is placebo, and the Trentol, the old drug. You can see there's basically no difference. And the dashed line is the Cilostazol, and it shows, again, about a 50 or 60% improvement in symptoms. And it took about 24 weeks, so that's about 4 months to get a maximal effect. But you can see that there was a gradually improving beneficial effect throughout the course of this particular study. And so this is the medication that we recommend if someone wants to try non-interventional management. Let's see, sorry, my slides got a little out of order. So this is a study looking at Cilostazol and quality of life. And what's so interesting about this is that not only is the medication improving their symptoms, but it's improving their quality of life. And so these are patients who, chose to take the drug because they wanted to see if they could walk more, and they found they could walk more, and their quality of life was better. These are patients who were very satisfied, who never required an intervention. And so for patients in this mild to moderate disease category, it's a very important adjunct in terms of managing the patient. We're going to talk a little bit now. We're going to shift over to improving cardiovascular risk. And as I mentioned, this is, to me, is the really important point. This is what in my mind is sort of that holistic thing is, you've got peripheral arterial disease, it's mild or moderate, we can manage it with a variety of things, but you're at increase for a heart attack or stroke, and there's things we can do to really decrease those risks. And so we want to approach all your risks that the PAD portends. And so we start out with the antiplatelet agents, and these are aspirin, and you might hear Plavix. Clopidogrel is the generic name. And there's been many studies over the years that have shown that for patients with cardiovascular disease, that there's a benefit in you can see this slide, it says event rate. When you see event rate, that's a combination of a heart attack, a stroke, or a death. When compared with placebo. So no question that an antiplatelet agent, as long as there's no side effects or contraindications, is going to be valuable. So that's sort of the first step. The second medication is statins, and we want to have statins in the water, because there's just so much good from it. If you talk to the endocrinologists who work with a lot of diabetes, they want metformin in the water because there's a lot of good benefit from the metformin too. It's one of the diabetic drugs. And in fact, interestingly enough, not so much for peripheral arterial disease, but as an aside, there may be a relationship with metformin and abdominal aneurysm disease. So we may end up jumping on the metformin bandwagon at some point. That's another talk though. So this is a really busy slide, but basically what this slide is saying is that if you have vascular disease and you go on a statin, you're going to decrease your risk of having one of these fatal events by about 25%. So there's hundreds of studies with all the different kinds of statins, and they all show some benefit. And for the subgroup of these studies for patients with peripheral arterial disease, there's a big benefit. And so if you happen to be my patient, I'm going to always ask you if you're on an aspirin, and I'm going to always ask you if you're on a statin. And this is why, because I'm not really focused so much on the vascular component of why you're coming in, but the overall cardiovascular health. For someone with moderate disease, we recommend high-dose statins. So, and the ones that are best studied are atorvastatin, which is Lipitor, somewhere between 40 and 80 milligrams a day. Or the other one, sometimes there can be some side effects with muscle cramping. We'll talk about that in a second. Rosuvastatin, the trade name is Crestor, has a much lower incidence of those side effects, and the dosing for that particular drug is a little different, 20 to 40 milligrams a day. These medications get a bad rap, but the truth is, when it's actually studied, the risk of side effects is very small, less than 5%. Patients can get them. They can get headache, nausea, sleep disturbances, liver dysfunction, especially if they have underlying liver disease, and the whole issues around muscle pain and cramping and muscle injury. And of course, it's always challenging because, remember, these patients came in with muscle cramping. That was their peripheral arterial disease, and so sometimes it's hard for us to, reassure our patients that no, this is your arterial disease, not from the medications. And there's a variety of ways that one can go about trying to get people on these medications, slowly. There are also some drug interactions, especially with Coumadin. There is an interaction with digoxin, but thankfully almost nobody's on digoxin anymore. Been a lot of study looking at statin adherence, in other words, how well people continue to take the medications. And unfortunately, a lot of people do stop taking them. It's actually not because only about 1 out of 20 patients stop taking because of side effects. A lot of it's because of polypharmacy. So for example, the more medication someone takes, the more likely they're going to have some kind of drug interaction or side effect. And a lot of these patients, because they have a lot of these other conditions, are on a lot of medications. But there's also, I think, this misperception of that patients don't have a higher risk of these events, and so you don't have any symptoms, so they don't take it. And there's these commercials out there right now. It's for some diabetic medication. I can't remember which one it is, but they're interviewing diabetics, saying, "Hey, do you know you have an increased risk of heart disease?" They're like, "Oh no, I'm diabetic. I don't have an increased risk of heart disease," and they do. But they talk about some diabetic medication which might have some benefit. This is the medication that those people need to be on, and anyone with vascular disease. And so it is a challenge because they do get a bad rap, and sometimes it's very hard to separate the side effects of the drugs from the symptoms of the underlying conditions. But I do strongly recommend them, not only for secondary prevention, meaning if someone had an event to prevent a secondary event, but for primary prevention, meaning you have vascular disease, you're at increased risk for one of these events, and even if you haven't had one, we want you on them. And so this is just a little summary of the four different treatments that we talked about. The antiplatelet agents, aspirin or Plavix. These are treating cardiovascular risk, but not the symptoms. Statins, same thing. Cilostazol or Platol doesn't reduce cardiovascular risk, but does improve symptoms. And exercise tends to decrease the risk in both categories, which is again why I favor exercise, even if someone chooses to go on to treatment for their vascular condition. So this is just a real quick slide to remind you that if the symptoms are severe, or if this non-interventional approach is unsatisfactory based on what a patient's expectations are, then we will start to talk about other options, whether it's either angioplasties and stent or surgical bypass. There's a lot of modalities of treatment. The data is not great. It's not consistent. We do have some newer technologies that have been out now for about 4 or 5 years, which are actually quite good under the right circumstances, and we have access to all the newest stuff as well, of course. And so if somebody's interested in treating, then we'll have that conversation. And so I'm going to stop there. I'm happy to take questions. I will tell you, and I almost hate to say it, but I will, that not only am I the medical director of the vascular lab, but I'm actually the medical director of ambulatory care. So I oversee, along with one of our VPs, all of the non-cancer clinics. And we really work very hard to try and improve the patient experience across the board. So if someone happens to have some questions in general, I'm happy to take those as well. So thank you very much. Yes, sir.
My relatives in Colorado, when they get a lipid test, they measure VLDL, which I've heard is more significant than LDL. I don't think Stanford measures VLDL, do they?
So there's a lot of controversy because the guidelines, the HA, the American Heart Association, and the CHEST guidelines for managing the hypercholesterolemia have changed. Historically, people looked at the HDL and the LDL and were treating down to certain levels, and then they changed their guidelines a couple years ago, and they're recommending treatment based on risk. So in other words, if you have diabetes, or if you have there's a risk calculator for the risk of cardiovascular events, and basically if your risk of a cardiovascular event is over in 10 years is over 7 or 8%, then they recommend putting you on a statin, and that statin might be low or high dose. But our cardiologists actually are not using the LDL, HDL, or the VLDL anymore for determining whether the efficacy of the treatment. For the risk calculators, what they found is that the VLDL didn't really add that much, and so that was actually taken out of the risk calculator. So HDL and LDL are in the risk calculators in terms of estimating your risk of having a cardiovascular event. But it's constantly changing. I mean, with the exact same, you have to understand, with the exact same data, everyone flipped everything around and changed the recommendations.
Well, the Stanford measure, can you have them measure VLDL? Very low.
Yes, Stanford will measure anything. So, and if they can't do it, then if we can't do it ourselves, we'll send it out. And there's a lot of things that we do send out. We don't routinely measure the VLDL because we haven't found it to be that clinically valuable at this point. Yes?
Two questions. Ornish's work on reversing heart disease seems very relevant and related, potentially. The reversing word is a very holistic word,
Yeah.
which you haven't used whatsoever. I'm curious about the possibility of reversing PAD and whether that's a useful way of framing the question. And the second, to the role of telemedicine. And
Okay. Yes, those are. Sure. So the first is can PAD be reversed, and the second is the role of telemedicine. So in 2017, there's absolutely zero evidence that PAD can be reversed, and we don't really approach it that way. I will say that sometimes we'll have patients with isolated carotid artery disease that we watch, and we put them on statins. In that particular population, we do sometimes, occasionally, we'll see partial reversal of the disease burden in the blood vessels. We never see the disease burden go away completely. And so we don't have any proven treatments for reversal. Is that an aspirational goal? Well, sure, of course it is. But we're really not close to that right now. But what we do know is that with the treatments that I've described, because if the disease can be identified before it becomes symptomatic and you can halt the progression of the disease, and people can live with that disease for many, many years. Just like if diabetes is well controlled, HIV now, people can live with it as a chronic disease for years and years and years. And so that's what we can offer. Now, in terms of telemedicine, it's an interesting question because we've sort of talked about this not only at the local level, but at the national level as well. There's a couple places nationally who are doing some pilot projects with PAD. Henry Ford in Detroit is the one I'm sort of most familiar with. And it's challenging because without being able to either do a physical exam, actually feel the pulses, or do the vascular exam, the non-invasive studies, the ultrasound studies, it's hard to get a good answer. And so unlike, for example, dermatology, where if you can get a picture of a lesion, it can be extremely effective, it's really challenging. And in fact, and I would say this, let the buyer beware when it comes to getting non-invasive studies. So we didn't talk at all about the trucks that go around, the life scans, where they do all these scans. There's actually no evidence that really makes much of a difference, and that's actually been well studied. The U.S. Preventive Services Task Force has recommended against all of those, against the carotid ultrasound screening and ABIs for the general population for abdominal aneurysms, and that's another topic, but certain populations do benefit from screening. But part of the issue is that the technologists have to be really highly qualified in order for the results to be meaningful. And we have a nationally accredited lab, and we repeat studies every single patient we get, because I would say at least 30% of the time we find our findings are very different compared with the studies that were done on the outside. And unfortunately, they're different in both directions. Sometimes we find more disease, and sometimes we find less disease. And so for evaluating a new patient with telemedicine, it's pretty challenging. For routine follow-up, for patients who we've already seen and they don't want to come from far away for a routine visit, either for untreated disease or even for treated disease, we can do telemedicine. We don't really have a formal program right now, but sometimes we'll have their patients get their scans locally. So we're sort of in the middle, trying to find a way to make it happen. But the technology that we have right now, it's not quite there. I will say some of the companies, GE, for example, or Philips, that are making the ultrasound equipment, they're coming out with smaller and smaller equipment that's more and more portable that can be, read remotely. And so it may be in the future. We're just not there right now. Yes?
What's the difference between pain and cramps? I always thought cramps was a tightening of the muscle.
So every patient describes it a little differently. So they'll come in with pain, but when you start to really drill down, it's cramps that they have. Sometimes patients say they have shooting pain, which may not be a vascular condition. Sometimes they'll say they have a bursting or a tightness in their leg, which tends to be a venous problem. And sometimes they'll say their leg just gets tired. So, when we see the patients, when they get referred to us, it'll say from the doctors saying something like, rule out vascular disease or leg pain. It doesn't necessarily mean that that's what the patient said to the physician, but that's the information that we get. But understanding the quality of the symptoms is the most important thing. And some people equate cramping and pain as cramping is just one type of pain.
Second question, why does cholesterol work?
The Cilostazol?
Yeah, why does it work?
Nobody knows. So it's a phosphodiesterase inhibitor, which basically means that it robs the cells of ATP, which is what the cells need for energy. This is why with patients with congestive heart failure, it's thought to be contraindicated because it interferes with the muscle action of the heart. And what's thought to happen is that it interferes with the metabolism of the blood vessel wall, and the vessel wall tends to dilate with time and recruit more collateral circulation. But with statins, nobody knows how statins work either. So we know that they lower cholesterol, but there is tons of evidence that even with patients with normal cholesterol, benefit if they have vascular disease or cardiovascular disease, benefit. And this is another, conversation that I'll typically have with the patient. Say, they check my cholesterol, it's fine. I say, well, it turns out that these medications have other effects which are beneficial. And if you read about it, they call them pleiotropic effects, which is just a very fancy medical term of saying something's happening, we don't really know what it is. But there's definitely benefit for those medications. Huh? Pleiotropic. Even for patients with normal cholesterol. Yes.
How about, from a dental standpoint, there's inflammation that we're controlling in the dental office, and then, whole body inflammation does inflammation have anything to do with, what we're seeing in the endothelium and the cardiovascular system? Is there an association there where we could help out?
Probably not. I mean, most of this is an atherosclerotic process, so it's...
What you're saying is basically cholesterol driven.
Yeah.
There's no inflammatory issues with that, then you're saying?
For the tip, if you do a biopsy of a blood vessel for typical atherosclerotic disease, you don't see an inflammatory response. There is a whole set of vascular conditions.
But could an inflammatory have caused it? That's what I'm saying. Maybe
No,
we don't say
no. So we think that the process is something called efferocytosis, or the inhibition of efferocytosis. Efferocytosis is a Greek word that basically translates into remove the dead. And so in many parts of the body, when cells die and turn over, they're removed. But for some reason in the circulation for these patients who have these conditions, the dead cells don't get cleared and they tend to accumulate. So there may or may not be an inflammatory component at some point, but that's not really thought to be the primary cause of this condition. And people have looked at prostaglandins, prostacyclins, and anti-inflammatories, and they really haven't found that there's been any benefit. In fact, if you look at some of the other non-steroidals, they actually have an increased risk of cardiovascular events compared with the low-dose aspirin. Yes?
My understanding is that clopidogrel Plavix, the main effect is to prevent the platelets from forming fibrogen. And normally they want it to not have fibrogen formed on a foreign body in the artery. But if you just have peripheral artery disease, do we understand how not having fibrogen in the...
So it's not exactly the fibrinogen. So platelets so if someone's bleeding, for example, the normal function of platelets is, if someone's bleeding, the platelets, which are a factor in the blood, they go to the site of the bleeding, they start collecting and they aggregate and they form clumps, and that helps set off the fibrinogen the clotting pathway, which ultimately will turn into, fibrin into fibrinogen and cause the clot and stop the bleeding. That's the normal function for platelets. But what happens with patients with vascular disease is that you can imagine when a pipe starts to get filled up with stuff, it's not smooth, it's rough. And that's true with a blood vessel as well. And the platelets tend to stick to these rough spots and cause thrombosis, these clotting episodes, cause these to occur. And so the benefit for the antiplatelet agents, aspirin, Plavix, there's other new ones, there's ticagrelor, prasugrel, there's a whole new set of these medications, is to keep the platelets from sticking to the blood vessels, because that's the first step when these thrombosis events occurs. And you can imagine if a thrombosis occurs in a heart vessel, that's what causes a heart attack. So it's more complicated than that. There are other causes for heart attacks, but that's the value of the Plavix and the antiplatelet agents. This is why they're thought to be helpful. Yes?
You mentioned Cilostazol.
Yes.
It raises your ATP in the body, gives you more energy.
No, it interferes with ATP. Yeah. It doesn't cause people to have less energy. The main complication, the main side effects are GI side effects, nausea, diarrhea, and a lot of times, but they tend to be pretty mild, especially compared with when we used to use the Trentol, the pentoxifil, and that was.
No natural product or supplement who can replace Cilostazol?
No.
Has there been in the market?
No. There's been a lot of things that have been studied, including ginkgo and a lot of other things, and none of those studies have been. None of those studies have demonstrated any benefit in symptoms. And yes.
A couple of years ago, I was in a study about the calcium releaser for PAD here at Stanford. Whatever
Calcium
happened to that?
release. I'm not sure what you're referring to.
It's from Psychokinetics, it's a calcium releasing drug.
Oh, you mean the chelating agents? That must be what you're talking.
I thought it was a calcium releaser that's supposed to activate the muscle. Yeah, the opposite of a calcium blocker.
I don't understand.
No, I'm not familiar with any of that. I mean, we have patients who are on calcium channel blockers for their blood pressure control, and there seems to be some benefit in overall cardiovascular risk. So no, not aware of anything. Sure, last question.
Is there any value in tracking the pulse pressure, the difference between systolic and diastolic, in terms of understanding whether somebody's got atherosclerosis? I thought I'd read that.
No, so what we do in terms of monitoring the atherosclerosis, it's the difference between the systolic pressure in the arm and the systolic pressure in the ankles. That's what this ankle brachial index is. And so we will follow that along and correlate that with the symptoms that patients have. And in fact, for my patients who I'm following for, with peripheral arterial disease, either those who we haven't treated or those who have, that's a critical component to the visit. Because if someone has, so a normal ratio is 1 or 1.1, so, or anything above 0.9. So if you have more than 90% of the blood flow to your leg that you do then to your arm, then that's considered normal. A typical patient with mild to moderate disease might have 0.7, meaning they have about 70% of the circulation in their leg. And so what we do when we follow them year by year is to make sure that with the exercise, the medications, whatever treatment regimen we've done, that 70% remains stable, which is an indication that the disease is being controlled. So, but that's a difference between arm pressure and leg pressure, not the difference between the two numbers. Okay, well, thank you very much for coming. I appreciate it. I do have some business cards. I'll leave with you if someone wants to grab them. And again, thanks for coming this evening.